Great. Well, thank you so much for having us here. We flew in yesterday and got a chance to experience some of the sunshine. So that was really nice. If y'all know anything about Seattle, we're just now leaving the big dark and just now getting some sunshine. So this was an absolute treat. Um, so thanks again for having us here. Dana and I will be talking about a qualitative study to describe Indigenous social drivers of health from the perspective of Indigenous people living with HIV. Sometimes the pictures don't show up for everyone. Is that showing up on Zoom and everything? Okay, good. Yeah, so I always like to start these talks off with a little bit about myself and where I come from. As Justin mentioned, I'm a citizen of the Apsalalka Nation. I grew up in Everson, Washington. And I always get my left and right mixed up on slides, but I'm going to guess that this is the right side of the slide. There's a picture of my graduation where my mom, dad, and my partner all came out and celebrated with me. This was summer 2022. And then below that is all my friends from undergrad came out and celebrated the graduation as well in September 2022. They all came up to my hometown of Everson, Washington. So that was really fun. On the other side of the screen is a picture of two cats. One is Ishpiwich cat, or Snuffers. We picked her up in New York, and then below her is Matai, and we picked her up in Seattle. In the center there is a picture of my dad, my sister, and my partner. This was my first time bringing my partner back home to Everson, Washington. And like we all do in small towns, we went down to the river and threw rocks at logs. And so that was really fun for us, actually. And then there's a black and white photo here of one of my ancestors. His name is Shot in the Hand, and he's wearing conch shell earrings like I am today. So I'm going to pass it off to Danner to do the introduction, and then I'll pop back later to talk about the rest of the slides.
Hi, I guess it's still good morning. Yeah, it's 11. So my name is Danner Peter. I grew up in a small town next to the Navajo Reservation in New Mexico. And I'm also a PhD student. Oh, I'm a PhD student at the University of Washington in the Biomedical Informatics and Medical Education program. And I currently work part-time at the Northwest Portland Area Health Board. Also, right next to me in the picture is going to be the love of my life, Dr. Von Peter, PhD. I like to say his background information is he has his PhD in forensic anthropology because he loves sniffing at a good crime scene. Yeah, and he just definitely knows that he is IQ and he doesn't use it to his advantage. Just to preface, I like to have more of an interactive presentation. So rather than talking at you, I'll be talking with you. Well, ish. Hopefully I can get you all to participate, which would definitely make me feel less nervous. So, please. So just to give you a bit of direction about our time together, we are going to cover the social drivers of health from the perspective of Native persons living with HIV. And I'll be covering HIV and its impact on Native peoples, and also the social drivers of health and how we think about them. And I'll also finish up with the problems we're trying to address with this research. After that, I'll pass it off to Oliver, who will cover lessons we've learned from our community action board. He'll review some preliminary results that we've seen from our interviews and wrap it all up with a quick summary. So, HIV has caused millions of deaths and has been one of the more devastating diseases that we have known. In 2022, the CDC has estimated approximately 1 million cases for HIV prevalence throughout the general US population, and a little over 3,000 cases in American Indian and Alaska Native populations. So if we imagine a group of 100 Native persons living with HIV, 76 will have received some form of HIV care. 54 will continue to get care, and 65 will reach viral suppression. And so we're now at a point where new advances in modern medicine have allowed us to manage HIV with a single pill once a day. And these are generally called antiretrovirals, ARVs. And in persons living with HIV, ARVs can dramatically reduce HIV transmission. And this is called treatment as prevention. And treatment as prevention is based on the idea that a person living with HIV who is taking their medication regularly can lower their virus levels in their bodies until it's become undetectable. That doesn't mean that the virus is gone. It could still be hiding within the cells, ready to activate if treatment ever stops. So that doesn't mean, but as long as the virus is kept dormant with drugs, HIV remains undetectable. So when HIV is untransmittable or undetectable, it's untransmittable too. So as you can imagine, getting access or getting these life-saving preventative medications can become difficult, especially for people to access and continue taking daily. So to understand why some people fall out of care or struggle to reach viral suppression, we need to look at the social and structural factors that shape health. So quick raise of hands. Who all knows what the social drivers of health are? Great, thank you. So the CDC defines the social drivers of health as the conditions in our everyday environments where we're born, where we live, work, age, and that influence our health and our quality of life. So another way to think about this is what are the non-medical things that affect your health? So SDH, social drivers of health, shape outcomes by affecting people's access to resources, environments, behaviors, and healthcare through social, political, and economic structures. So these have been defined by the CDC into 5 domains: education access, healthcare, built environments, social and community context, and economic stability. So as you can imagine, these social drivers can influence HIV care and retention. For example, substance use is associated with inconsistent viral suppression among male and gender minority PWLH. Insurance status is linked to missed appointments among Black and white PWLH. And cultural factors can also shape care experiences. And this is including gender identities that diverge from colonial norms, gender expectations within Latinx communities, indirect communication patterns among African American patients. So now that we've covered the social drivers of health, you're probably wondering, how is this all recorded within a clinical setting? Well, I hope you're wondering. So quick raise of hands. Do we have any clinicians in the room? No? Oh, cool. So these are up on the screen is what are known as ICD-10-Z codes. And they're a group of medical codes that capture a broad range of social drivers that can be used by researchers, health systems, payers to integrate social care into healthcare. They also come with their own issues. They're often underutilized. Some clinicians may struggle to use them, and it's unclear whose responsibility they are to collect and document. And additionally, it takes away from provider time. So another example is from the Centers for Medicare and Medicaid Services, or CMS. And they use something called the Health-Related Social Needs, or HRSNs, to find out whether things like housing, food, transportation affect the total cost of care, and whether addressing these needs can actually improve health outcomes for Medicare and Medicaid patients. So this helps providers identify patients' needs across 5 core domains where community services can step in and help. So this is, there would be housing instability, food insecurity, transportation issues, utility needs, and interpersonal safety. So in this presentation, we're going to refer to both of these as the commonly referenced SDH codes. So these are SDHs that we usually see in a clinical setting that might be used in things like quality reporting, billing, et cetera. So what about the Indigenous representation aspect of it? Like, why are we up here? You see 2 Native guys up here, but why? So diving into the Indigenous drivers of health, these are much like the social drivers of health, but they are specific to Indigenous people. Dr. Christina Ore from 7 Directions points out that the standard SDH frameworks often miss cultural and contextual factors. Things like Indigenous health beliefs, knowledge systems, and healing practices that are all central to how health and wellness are understood in tribal nations. So our First Nations relatives in Canada have identified shared determinants that go beyond SDH and work towards reclaiming Indigenous health. And these include recognizing the lasting impacts of colonization, honoring Indigenous knowledge and healing practices, and also centering Indigenous voices and leadership. So Ore then uses this knowledge to develop these broad concepts for the Indigenous social drivers of health, and has broken them down into 4 areas: language and identity, land and kinship, indigenous knowledge, tribal sovereignty and governance, all of which play a role in community health and well-being. Dr. Stephanie Russo-Carroll from the Native Nations Institute here at the University of Arizona is honestly doing some amazing work. I love to fangirl over her papers. Has published a paper on how we should be rethinking and conceptualizing the social drivers of health as Indigenous people. And they've done so by categorizing them into 3 domains. Broad drivers that affect both Indigenous and non-Indigenous communities, things like governance, community cohesion, and jobs. Shared drivers among Indigenous, cultural, or regional communities, and these things are resilience, transgenerational relationships, and relationality. And then finally, the unique drivers that are found in one or a few Indigenous communities, like culture, natural resource use for healing, traditional ceremonies, our language. And one thing that should be noted is that the commonly referenced SDOHs apply to everybody in some way or another. However, they do not cover the important aspects described by Ore or Carol. So this brings us to the main problem that we're trying to tackle. The first being that Western medicine is missing culturally congruent social determinants of health that are based on Indigenous perspectives and knowledge. Remember how I mentioned the commonly referenced SDH codes that don't cover Indigenous contexts? These would be things like colonization, health of lands, spirit, animals, language, gender, and sexuality concepts that precede colonization. And building on these codes is going to be difficult, mostly because of mistrust. So one way to remedy this issue of missingness is to go to our Indigenous peoples, our aunties, our uncles, and listen to their stories and engage with our knowledge systems. Historically, researchers have not had a good track record of when it comes to engaging with marginalized communities, especially Indigenous communities. This is rooted in a long history of colonization and harmful research practices that have often exploited, misrepresented, and ignored Indigenous peoples. So if we're going to work with Indigenous knowledge on social drivers of health within Western medicine, we have to start by acknowledging that history and the lack of trust many Indigenous communities feel towards Western biomedical researchers. So that's why this work must be informed by Indigenous perspectives. Community voices are where the knowledge lives. And if we want to understand the true social drivers of health or of Indigenous health, we need to look at the Indigenous communities themselves, not just as participants, but as knowledge holders and partners in shaping this research. So as you can imagine, when SDH categories are created without Indigenous input or direction, and Indigenous people continue to be underrepresented or misrepresented in research, a critical gap begins to form. And this gap results in incomplete or inaccurate representations of the lived experience Indigenous people living with HIV, ultimately limiting how effective their care and our care and prevention strategies and support strategies can be for them. So with all that being said, our purpose for our work is to partner with community to collaboratively describe the Indigenous social drivers of health for Indigenous people living with HIV. And in this presentation, we'll walk through our overall approach, which centers on community engagement methodology, as well as qualitative interviews. So right now I'm going to pass this on over to Oliver, who is going to talk about our approach to building respectful and reciprocal relationships with Indigenous people in the Seattle area. And they'll be the ones who help guide this research, the analysis, and how we disseminate our results.
So much, Danner. Great job up there. Yeah, and so Danner is a mentor or a mentee that I'm working with, figuring out what their dissertation is going to be about. And I think that the methods that we talk about today in this talk will be very relevant to Danner and all the cool work that he's going to be doing, as well as I hope it'll be relevant to everyone here for this talk too. So there are two main moving parts that we're trying to address. One is building trustworthiness for biomedical researchers, which I include myself as a part of. I may look the part, I am part Native American, but I did not grow up on the reservation, and I spent a lot of my life in Western academia, so there's a lot that I have to learn and unlearn when working with Indigenous communities. The second is the wealth of knowledge on health and well-being from Indigenous perspectives, cultures and knowledge systems that can inform how we provide care and collect information on social drivers of health within the electronic health record, which is not currently a widespread part of the data capture process. So this next section of the talk is going to be about a community advisory board, which is the abbreviation you see at the bottom of the screen, CAB. And I'll introduce the importance of working with CABs and how we approach working with community advisory board members for this research as well. And finally, I'll talk about some lessons learned, which will hopefully be useful for anyone looking to work with Indigenous people, as well as other marginalized communities. I'll then present some preliminary results from our qualitative study to describe social drivers of health from Indigenous perspectives. This will include a quick overview of our approach, how the Community Advisory Board changed our approach, and then a connecting narrative across 3 cases or interviews. So I'll first start with the Community Advisory Board and lessons learned there, because working with Community Advisory Board members has really helped us figure out how we want to approach this research. So we are absolutely not the first to come up with community advisory boards. CABs are an important tool in community-based participatory research approaches, or CBPR. So CBPR is a set of approaches that supports collaboration and co-leadership between researchers and communities. CBPR focuses on strengths of a community rather than deficit narratives, which we're very used to seeing in Indian country. And these approaches can help build trust and transparency through working with communities as co-leaders in the research process. And so what co-leadership means here is sharing power, making sure that it's not just researchers who decide how research happens or what questions we're trying to answer, but making sure that we are bringing expertise from both sides to address these problems. And CBPR can also lead to improved outcomes when we're working with communities to address the problems that they care about most, while relying on their strengths to take action. And the main method that we relied on from CBPR is through community advisory boards. And CAB members often have expertise and experiences and leadership positions that allow them to represent a community well and to guide research. That's not to say that even a group of people can represent a community overall. I know that's a loaded phrase to say, but we are working with people who can help us start these relationships and help us do good work within these communities as well. And so we balance attributes such as being local to Seattle, lived experiences with HIV and/or inequities and health drivers, clinical or professional expertise with social drivers of health or HIV, and Indigenous health advocacy or organizational leadership. So we requested introductions to CAB members from Indigenous serving institutions and research groups within the Seattle area, and they were gracious enough to help us make these connections and vouch for us. And engagement activities began about 17 months before submitting the grant and 24 months before funding was secured. The Seattle Indian Health Board was one of the first organizations to help us make introductions. They introduced us to an elder, a Tlingit elder, who does a lot of community activism within the Seattle area on HIV, and also has a lot of knowledge on the science of HIV as well, and presents at national conferences. By the time that meetings began, we'd recruited around 7 community advisory board members, all from various tribes within the US, 3 of which were elders. And so now we've held a few community advisory board meetings, which happen about monthly. The first community advisory board meeting focused on laying out the high-level research plan and drafting a document to set expectations and values for working together and fostering a collaborative environment. The second meeting focused on questions and discussions about the initial research phase, and then drafting a document outlining our principles for engaging with communities and conducting good science within Indian country. The next 2 meetings focused on refining our recruitment and data collection methods and materials. And so this includes where to recruit and what our interview questions will be. The 5th meeting focused on drafting a dissemination plan, outlining our responsibilities to share our research with the surrounding communities. And future meetings will continue to shape research through qualitative analysis and preparation to move into future research aims. So there are three main guiding documents that we've drafted to help us do this work together. The first is a document on our expectations and values for working together, a document on community engagement principles, and a final document on our responsibilities to each other and our community when we are sharing research. So I'll talk about those documents in a little bit of detail now. The first document on our expectations and values for fostering a successful collaboration include principles like leading with love, compassion, humility, and bravery. And if any of you have worked with me in the past, you know that humility is a big part of how I like to conduct myself, as well as my science. But bravery is also important because without bravery, we won't have the push to make change within our own communities. And so bravery was an important part of our community advisory board meetings that we discussed. It's also come up in some of my past work with the Justice Informatics Collaborative at Columbia University. We also strive to do good research within Indian country. And this includes respecting ourselves and our communities and focusing on mutual benefit, and boils down to holding ourselves accountable to do something good for our relatives and our kin. And another value is to build meaningful relationships within the study team and the broader community. This focuses on taking time to engage with community advisory board members and the community at large to foster relationships beyond just research partners. And this can include attending community events like powwows and fun runs. And if I'm going to be honest, that's probably the hardest part for me. As we all know, academia takes a lot of our time, even if we do enjoy the work that we do. So I'm trying to slow down a little bit and engage more with the communities that I'm working with here. The second document stems from two questions. What does good science in Indian country look like? And how do we do good science in Indian country? This document outlines our community engagement principles, including uplifting Indigenous health, respecting the plurality of cultural values, practices, and perspectives. This means that there's likely no single truth with a capital T when you're working with Indigenous peoples. And then acknowledging the systems that we work within, which is to say that my training puts limits on how I think and approach problems, and that Western academic systems have certain norms and standards that can provide limitations when engaging with different communities. The third document sets out our responsibilities to share our research within the Community Advisory Board and broader community. It includes principles like spending time to review documents and ask questions, providing enough time to review documents and ask questions, and then seeking opportunities for feedback and course corrections from tribal nations and organization leaders. So identifying who to work with, connecting with potential CAB members, and structuring our meetings, defining these guiding principles has really been a lot of really rewarding work. And I've learned a lot along the way as well. So the way that we gathered lessons was looking at artifacts like meeting notes, document drafting discussions, personal reflections, and personal communications. We also held some time to discuss these lessons with CAB members to provide feedback, as they are uniquely positioned to identify what lessons they hope other researchers will know when engaging with them as a community advisory board or co-leaders. So one of the first lessons we came across was that Indigenous people are not a monolith. Anyone who works with Indigenous people should be familiar with this. However, we thought it was important to lay this out explicitly. And so this can show up in differences between and within tribes for customs, meeting protocols, cultural connections, which can be across the scale, and gifting protocols. And so I came across this pretty early on when working with an elder. What I had been taught in my own tribe is that when you go to an elder and you listen to their stories and you spend some time with them, when you shake hands before you leave, you slip them a 20. And this is something I learned from my dad. And this elder, this wasn't something that he did in his culture. And he was graceful enough to decline that in a really kind way, but I felt incredibly sheepish afterwards. But I've been able to talk to him, and we found a way where I can show my appreciation for the time that he spends with me by buying him coffee and meals whenever I can. The second lesson is one I think that anyone who does community engaged work should be pretty familiar with, but it's our responsibility to adapt our communication to general audiences. And I thought I had done this for our first meeting, first community advisory board meeting, but people noted that there was still a lot of jargon, which makes sense because I'm pretty steeped in my own field. So sometimes it's hard for me to spot when I'm relying on language that I'm familiar with, but others outside of the field may not be. So during our first CAB meeting, multiple members mentioned that abbreviations and terms be clarified and introduced a bit better. So now, before each meeting begins, we provide jargon sheets and general audience summaries for all publications and submissions. The third lesson is to highlight the expertise of community members that we work with. And this one hits close to home for me because it took me a while to find my own voice when it came to working in academia, especially within the American Medical Informatics Association community. But I had a lot of people who've been really great to work with and remind me of all of the expertise that I bring to the table. So it only makes sense that when you're working with community members, you may have to remind them that they were chosen, they were reached out to because of the expertise that they bring to the table. And there are things that they think about, there are experiences that they have that I just don't. But this one can be especially challenging when you have differences in degrees on a community advisory board. We have some people who have terminal degrees and some people who don't. And so it's really important to highlight the expertise that each community advisory board member brings, as they were all recommended to us by people within the community. And so this is something that we as researchers can do, but it's also something that I've seen happen within the community advisory board naturally too. So when we're working with elders, they play an important role in mentoring and uplifting people. And this goes for uplifting and mentoring community advisory board members, as well as researchers like me. The fourth lesson is to promote transparency about the limitations of Western research approaches. So we try our best in this research to align our approaches, analyses, and interpretations with Indigenous values. But there are times when we come into conflict with how Western science works. So being transparent allows us to manage expectations while working towards solutions in the future. These discussions can also be helpful when we're talking to tribal leadership to help make sure that everyone is making an informed decision at the group level when choosing to participate in research in the future. And so this can look like talking about the limitations of Western science with communities, community leadership, so that they know that this is something that we're thinking about and working to address in the future, even if we may not be able to do everything perfectly right now. So we learned this during a discussion about how standard interview approaches felt a little bit extractive, like putting a participant under a microscope. Unfortunately, we were able to find approaches that align more with our values, which I'll talk a little bit about later, but we rely on storytelling approaches in our interview guide. The fifth lesson is another one that should be familiar to anyone who spends time in Indian country, but our meetings run very differently. There's something called Indian time where things happen when they're supposed to happen. And so people may not always show up on time, but this also gives you time to just sit and visit with people who are already there, and can be a really nice way to move a bit slower and to build relationships with the people that you're hoping to work with far beyond this research project. And this also includes making time to visit and chat outside of meetings. Maybe this is grabbing coffee or driving someone to and from a community advisory board, but it's important to for me especially, to pull myself away from sitting in the office, sitting from my computer, and really just engage with folks who mean a lot to me and have done a lot to give time to help this research. So this was another one that we learned pretty early on when trying to conduct a meeting when I had the same number of agenda items that I would if I were meeting with a mentor or mentee. And we just weren't able to make it through all those agenda items in a way where everyone had enough time to think and really reflect and to provide their own input. And so slowing down underpins our approach to not only good science, but also building good relationships that we hope can last beyond the study. The final lesson is that you have to keep an eye on the big picture and the details during discussions and be able to weave those together. Of course, this isn't a one-shot endeavor, and that people also have to agree on what's been gathered and woven together. And so this came during a discussion on the question, what does good science in Indian country look like? We took time to gather statements. People did a little bit of brainstorming. And after the meeting, I was able to draft together a document where I interpreted what I thought was the underlying meaning behind what everyone was saying. And then we checked in to make sure that what I had woven together made sense and aligned with where they were coming from. So these are the 6 main lessons that I just want to present today and talk about that we learned from engaging with our community advisory board. And I want to present all of this first because, as I mentioned, working with the community advisory board members really helped us inform our qualitative research approach. So next, I'll talk a little bit about our qualitative research approach and some preliminary results from that research. So in discussing our preliminary interview results to describe social drivers of health from Indigenous perspectives, I'll briefly talk about how we approach this research, how engaging with community advisory board members changed that approach, and some preliminary results. So I'm going to keep this fairly brief, just keeping an eye on time here. So we're using a semi-structured interview approach as one of our goals is to elicit stories. And so we're going with pretty open-ended questions. We're following a directed content analysis approach, which allows us to have a more deductive phase where we're using the frameworks from Ore and Carroll for Indigenous social drivers of health. And then this also allows for an inductive phase too, where we can identify themes that might not fit perfectly into these frameworks. And as for one of the reasons we're focusing on working with people who are living with HIV for this research, as Danner mentioned, is that the important role that social drivers of health play in managing HIV. Social drivers of health are, of course, important for everyone, but especially in this population where different inequities and drivers of health are very prevalent. I'm going to skip over the recruitment criteria really quickly, but I do want to mention that in addition to a financial incentive that we offer participants, we also are providing a culturally appropriate incentive too. Some might call it gifting. I wouldn't put that in a grant, but it's a gift of four things: pemmican, coffee, sweetgrass, and abalone shells, all sourced from Indigenous businesses or Indigenous communities. So working with CAB members was instrumental in how we approach this research. And these are a few examples of some of our approaches that changed while working with the community. So the first was early on when we talked with the first elder that we were introduced to. And he mentioned that it'd be good if we worked with elders for this project. Partially because elders are not always a focus of HIV research, but also because elders are our knowledge keepers and they know so much about our traditional ways and histories that it makes sense to talk to them when you want to learn about this. Second is that we expanded our recruitment sites. Originally, we were looking at the Madison Health Clinic, which provides HIV care, and the Seattle Indian Health Board, which provides initial screening. And CAB members helped us identify more places that we could recruit from, put up flyers and reach out to. And I really think it was them making this connection for us and vouching for our integrity that helped these organizations feel comfortable working with us. Third is that we worked together to update our interview guide. So as I mentioned, initially we were going to have some methods that kind of felt like we were putting people under microscopes and asking them questions one after the other, which didn't feel right overall, especially for if I was going to be doing these interviews and talking to an elder, that didn't really align with how I'd been taught to talk to elders. So we moved to a more open-ended storytelling approach, which aligns with Indigenous cultural values. And finally, I'm going to be brief on this point, but we also measured how culturally connected someone feels to their culture too. And this is done during the interview process through a survey. And so we tailored this survey to working with Indigenous people in the Seattle area through the help and knowledge of our community advisory board members. So that covers the methods, our approach, and how we updated that approach in working with the community advisory board. And I'm going to zoom through the results really quickly, but I'm also happy to pause if anyone has any questions and go back later. So as a quick reminder, these are preliminary results. We are looking at 3 cases and finding connecting narratives across those 3 cases. I've organized quotes and discussions from participants under the 4 main topics of our interview questions. Cultural practices to support health. So what kinds of practices do you have that support your health? HIV management and health. How do you manage your HIV? Experiences in Western medical settings. What are your experiences like in Western medical settings? And traditional medicine and cultural health. What kinds of cultural systems do you engage with? And these 3 interviews do cover a broad range of factors that are important for health in Indian country as well. So I'll start with the connecting narratives for responses related to cultural practices to support health. So first, when talking about cultural practices to support health, participants discussed the positive aspects of connecting to Indigenous cultures, while also recognizing that this connection was not always a welcoming experience. For example, P845 discussed leaning into their traditional role in their culture to support addiction recovery, but that the trauma of coming out to one side of their family presented barriers to participating in cultural healing practices. They said, I think it just came from as growing up and coming out in fear of what people are going to think of me. And am I doing the right thing or am I doing it the right way? I stopped dancing when I was 16. When I came out, I was a Southern fancy dancer and I gave up. I just quit. And one particularly strong example from someone who talked about the strength of their culture that it gave them said, when I would be fueling myself with alcohol, then I'd start talking to the people who have passed. I'd even go to my friend's place that has my sister's eagle feather, and I'd use that on my body. My major takeaway from this is that To me, this points to the importance of connecting with culture, but that just like there are many different cultural practices, there are also many different paths to connecting with that culture or reconnecting. The second is that when discussing managing HIV and health, participants talked about the friction of stigma towards people living with HIV and seeking support from extended family. For example, P845 said, "I don't feel that there's anything special about our community because HIV is shunned in our community. It's not accepted in our community." But even with this potential for stigma, participant 484 saw some kind of connection. "Yeah, I wish a lot more of our cultural, even raised on the reservation, would have been a way better than her." They were talking about their mother, not having been raised on the reservation. I felt more family to fall back on when I got sick." And again, this points to a mixed bag. Of course, there is still stigma towards people living with HIV. This is unfortunately common in many different communities, but there can still be strength and support in connecting with our broad kinship networks. So when responding to questions about traditional medicine and cultural systems, participants expressed overall positive views towards Native American-focused health centers, especially when dealing with the ongoing impact of colonization on their lives and their health. So P845 noted that there was a kind of care tailored to being Native American. They, Native American-focused health centers, focus on your culture. They focus on you, not anybody else. To me, it's just that they primarily focus on you're Native and we're here because you're Native. You're important to your health and well-being. Additionally, P484 noted the historical trauma that still impacts their mental health. And I think back to they almost destroyed our people. And that's where my depression comes in. Even just thinking about that, I could almost start crying because of what they did, taking away our children from their families, dressing them up like little pioneers and everything like that, and taking our culture. P484 would go on to talk about not being able to talk about some of this root causes for their mental health and their depression, including colonization and boarding schools, just not being able to talk about that fully within non-Native contexts. And finally, for responses to experiences in the Western medical setting, participants noted a lack of recognition of Indigenous knowledge and values on health in these settings. For example, P916 talked about how Western medicine wasn't going to be the answer for everything that they had going on in their lives. He's, talking about a clinician, trying to push the pill thing on me. This is culture. It runs core deep. Pills aren't going to work for this at all. And this is when they were talking about communicating with their ancestors and animals when going for guidance. And this was the discussion from P484 I mentioned in the last slide, where they noted that they couldn't talk about everything with non-Native clinicians. I don't go into the heavy side of it, colonization, because usually it's easier talking to someone. I don't feel like I fit in all the time. It's easier talking to somebody who is Native, who understands. So these three cases portray a complex relationship between cultural connection, community, intergenerational trauma, and healing, which is important because while yes, there are difficult and negative aspects in these interviews, there's also hope and an acknowledgement that there is strength in culture and Indigenous communities to support our health and well-being. Our preliminary results demonstrate concordance with categories from previous research into Indigenous social drivers of health. For example, P916 would go to their ancestors for guidance and healing, which is a shared Indigenous determinant of health and part of kinship. While P845 noted the importance of filling a specific traditional role in their tribe to support addiction recovery, which is a unique Indigenous determinant and part of Indigenous knowledge. Finally, participants discussed wanting to learn their language, which is a shared determinant and part of identity or language. These stories indicate that commonly referenced social drivers of health are missing certain health knowledge and experiences for people living with HIV that can inform tailored care for Indigenous people, as well as potential Indigenous social drivers of health categories that can be captured within the electronic health record. So we're coming up on time, so I'm going to zoom through this part really quick. We talked a little bit about the importance of building trustworthiness for biomedical researchers, the importance of Indigenous knowledge when we were talking about health, especially for Indigenous people, but I really think that this knowledge can be useful for many different populations. And so we began to address these two gaps through talking and working with a community advisory board, as well as some of these preliminary interview results. And we are really incredibly lucky to be working with the Indigenous Social Drivers of Health Community Advisory Board, who I hope will continue working with us to future aims in this research as well. As we continue this work, we'll be integrating the framework by Ori et al. Into our analysis. And future aims will work to translate Indigenous social drivers of health into the EHR and informatics. The first, we'll be looking at clinical notes to see how and if Indigenous social drivers of health show up, and then using Indigenous social drivers of health to help us predict health outcomes for people living with HIV. And like I mentioned, I'm especially excited to work with the community advisory board members to learn about these interviews and to talk about machine learning to make sure that we're all on the same page when we move into aims 2 and 3 of this research. I have a lot of people to be thankful for here. First is my co-presenter, Danner. Like I said, even though I'm one of his mentors, I'm learning a lot from them. And this work wouldn't be possible without the community advisory board and their generosity to spend time with us and work with us. My mentors have also been incredibly supportive and open to learning along the way. And finally, my collaborators who are helping with the analysis and running these community advisory board meetings. We also have funding to be thankful for the from the NLM for a K99 and a training grant. All right, thank you everyone. I appreciate having you here and happy to answer any questions along with Dan.
I have a few questions. The room is mic'd, so just feel free to speak up.
I don't really have a question per se, but I wanted to just give an interesting perspective during the early 1990s, during what we call the AIDS epidemic, because everybody who was HIV positive died of AIDS. And we were working on a study in San Diego, and we found that people with a positive perspective, so everybody who didn't die of any number of the clinical kind of events that happened with HIV, had dementia. They eventually got dementia before they died. And so we were looking at that part of the process. And what we found was a positive outlook actually delayed that trajectory by a lot. And that was the only thing that we determined. It wasn't clinical, it wasn't biological, it was literally positive outlook. So it would really, I think, be really intriguing to try to leverage some community support to get that positivity and see if that actually helps quality of life and also the acceptance part in this work. So I'm just throwing that out there as something possibly to be explored, and maybe leveraging some of that early 1990s work on that aspect.
Yeah, that's really exciting. I mean, I'm hopeful that we can identify some of these more positive aspects of people leaning into their culture.
Yeah, exactly.
And, not just keep that in journals and pass it on to UW Medicine, but also pass that on to tribal clinics, tribal epicenters, Seattle Indian Health Board, to say like, these are possible avenues for interventions that we can work on where, like I said, hopefully in future studies, we can confirm that a positive connection to one's culture can lead to positive outcomes as well. So that would be
Well,
amazing.
we were talking before your talk about actually having that kind of tool on apps and on phones and on positive reinforcement of that using sort of social media as well. So, I mean, it's just a really intriguing time to try to leverage those kind of tools, and it's really good for rural-ish, populations.
Absolutely, yeah. Thank you.
I think you guys an amazing talk. When you interview your participants, do you see a difference between those who predominantly grew up on native lands versus those who either moved away when they were younger, or those who came back to native lands for one reason or the other?
Yeah, so I don't think that in this research, and Danner is something you've come across, but I don't think in this research we have enough data to say anything about that. I think we will see some differences there. Just speaking from my own experience in terms of cultural connection, I grew up off the reservation. There are ways I do not feel super connected, and I am trying to reconnect. So I think that will show up for different people. But yeah, it's something that we'll keep an eye on. But I'm not sure exactly how that might show up just yet.
Oh, I have no idea in terms of like how we'd be able to start looking at that from a clinical or non-clinical perspective. I'm also just thinking like logistics of like, oh, do we contact people or give recruitments from or natives not living on the reservation versus natives living on the reservation? What that data agreement's gonna look like. So, yeah. As of this time, I don't have any like hard results from that.
It'll be interesting to look at.
So I'm gonna play a little bit of devil's advocate here and ask an awkward question. Right now, we're seeing a lot of discussion of, let's just say, certain groups in this country have taken a very anti-Western scientific stance. A lot of them, let's just say, voted for a particular candidate recently. And the typical scientific community is basically calling these people lots of names and saying we need to protect science. Historically, the Western scientific community has said exactly the same things about traditional knowledge.
Mm-hmm.
How do we separate the I'm not sure I have the term, valid traditional knowledge from, I hope I don't offend anybody here, bleach and light bulbs?
Mm. Yeah, I think, yeah, I'll jump on that one first. Yeah, that is hard. I think in my conversations, I don't think, and this is just personal experience, I haven't run into any Native folk who are strictly anti-science. I wouldn't consider them in the same camp as folks who just don't believe science at all, no matter what kind of thing. I think it's more of we understand that there can be benefits, that there is a positive aspect to blending Western medicine and traditional medicine together and picking the best parts that work for our current context. But I think it really, for what I've seen, comes down to acknowledging some of those limitations and saying, great, how can we work with that? Work with you to understand those limitations, to improve those limitations, and not make Western academia such an ivory tower where it's, sorry, you don't understand this enough to have the input on this or something like that. How much that applies to different groups who are just strictly anti-science for political reasons, I'm not sure. And yeah, maybe it would be good for me to update how I talk about this too, so I don't seem like I'm falling in that camp or anything.
So what I'm reading between the lines of what you're saying, that the folks that you've talked with and your interactions with tribal communities, it's not an either or, it's not a tribal versus science perspective. It's rather a request that traditional science acknowledge tribal versus the politically driven, which tends to be a dichotomous either or, and I'm right, you're wrong dichotomy, as sort of either or versus both and.
Yeah, I'd say like I've seen people fall more on the both and side of things. Yeah, and my dad's one of those people who will talk about like, oh, this science article came out and look, they confirmed something that we've known for a long time. And so I think it takes people on both sides approaching the other side with genuine curiosity, like, what do you bring to the table? Here's what I bring to the table. It'd be great to combine those. So yeah, I don't know if you want to jump in too.
Oh, definitely. So it sounds like what you're describing is what there's been a few papers on, I think it was Canada, Canada has a few papers on what's called two-eyed seeing, and it's where you take one approach from one eye, which is Western knowledge, and then your other eye is going to focus on your traditional knowledge, your indigenous ways of knowing. And that's how we're able to combine both aspects into scientific literature. The problem is that indigenous ways of knowing aren't always, well, I should say, Western knowledge is not always accepting, at least accepting or without conclusive evidence, evidence to support that claim. And when you're faced with indigenous ways of knowing, elder knowledge, them knowing something that's been taken into, or that's been incorporated and been able, like, how do we,
Been passed down,
Yeah.
generation, but like something that we've known for a very long time that's helped us survive in many areas.
exactly.
Yeah. So I think looking at those as both valid, you're looking at those as both valid contributions and valid evidence.
Yes, thank you so much.
Thank you, Justin.
Really quick. Have you talked to the community advisory board about these learnings like machine learning? How are they feeling about some of these methods that are super technical?
Yeah, so the first community advisory board meeting, we went over all the aims. So it was an absolute whirlwind of here's all the science I'm interested in, which was a big learning, teachable moment for me, I think. But one of the ways I talked about natural language processing with them was just showing, here is ChatGPT, and let me write up a simple clinical note on someone living with HIV who recently went to a powwow and hurt their ankle, but their sister is living with them and takes care of them. And I asked ChatGPT, I'm like, hey, pick out the indigenous social drivers of health here. And it picked out some pretty decent ones. But I went to the community advisory board and I was like, what do you think of this? Are there any issues that you're seeing here? And one issue was that it's very pan-Indian. It's pan-Indian in the sense that like, it didn't take into account the specific context that this was in Seattle or anything like that. And so, while I think we have a lot of work to do to talk about like the specifics of how these machine learning models work, what I want to do there was show people like, you have good intuition, you have expertise that can help guide this research and talk about the problems that are happening here, even if you don't know everything that's going on under the hood. I don't even know what's going on under the hood all the time too. So that was one way we approached it, but I think it's going to be a big learning curve for everyone involved.
Okay, well, I think we're at time, so join me in thanking our excellent speakers.